welcome to COVID-19, Keeping Up with a Moving Target. I'm your moderator, Faith Rogers. Thank you for joining us. We are pleased today to welcome two expert faculty, Dr. Paul Auwaerter, Clinical Director of Infectious Diseases at the Johns Hopkins School of Medicine, and also Dr. David Klimpl, Assistant Professor at UC Denver. Dr. Auwaerter, Dr. Klimpl, thank you so much for joining.
Thank you, Faith. Glad to be here, and good day to everyone, and thanks for joining.
Fantastic.
Thanks, Faith. Appreciate being here.
Thank you. These are our faculty's disclosures today. This educational activity is supported by an independent grant from Regeneron Pharmaceuticals. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Please do note that the material presented is current as of today, June 30th of 2021. For the most up-to-date and contemporary guidance, we do advise you to go straight to the sources, NIH and IDSA. Our learning objectives today are to appraise the efficacy, safety, and indications for treatments for patients with COVID that require hospitalization, evaluate management strategies for outpatients with mild to moderate COVID, explain mechanisms of action of monoclonal antibodies and other current and in development treatments, and describe best practices for managing patients with COVID-19 with monoclonal antibodies and other agents. I'm going to hand this off to Dr. Auwaerter. Dr. Auwaerter, thank you so much for your time today.
Yeah, thank you, Faith. And again, many thanks to everyone who's joined. And my role before David takes on is to just give some background, many of which these aspects you may be familiar, but also give you a bit of a perspective for what patients may have available to them in the outpatient area, and hopefully avoid the need to be admitted to the hospital. Now, I think you've probably seen numbers like this for quite a while about the novel coronavirus, in that most people have mild to moderate illness or may even be subclinical and asymptomatic, but approximately 20% or so develop severe enough problems to be hospitalized. Of course, that's from early in the pandemic, when often elderly people comprise most of this. And as we move now, and you're probably seeing younger patients than you did a year ago be admitted to the hospital. This has perhaps changed and has clicked down a few more percentage points now that we have especially the elderly population more highly immunized. This virus, to me, as an infectious disease doctor, is fascinating in much the same way and terrifying that HIV is, in that this not only has a typical viral type phase, but also appears to trigger some immunologic perturbations that we really don't fully understand for a number of reasons. Now, the virologic phase is early on, often as the amount of virus peaks, and resembles influenza so commonly, except for the loss of taste and smell. So it's really indistinguishable. And this is where some antiviral therapies and perhaps antibody-based therapies can really have an impact. Now, often in that second week of illness is when we see in a subset of patients this kind of hyperinflammatory phase, often with worsening pneumonia, or even progression to lung injury and multi-organ system problems before hopeful recovery in patients. And of course, there are even longer lasting issues, as many of you are well aware, regardless of age, with this virus in terms of persistent problems that seem to go on for weeks or months in some individuals. Now, you've no doubt seen many of these patients in the hospital, but the risk factors for severe illness are very similar to what we might consider for influenza, with the exception that young people, meaning children and adolescents, are much less at risk for developing the the severe infection that would land you in the hospital. But on the left-hand side, the Centers for Disease Control has sort of gone through a variety of labels to denote risk factors, and now they've moved to an evidence basis. So the left-hand column are the ones that really there's abundant evidence to support, and the only ones I'd really point out now are that pregnancy is clearly and squarely in this category, and that's an important consideration for prevention purposes. But also obesity, and this is a BMI of greater than 30. But as you'll see, if you go to the middle category, even if you're overweight with a BMI of over 25, it may place you at some increased risk along with those. You know, interestingly, the mixed evidence is all the way to the right. And, you know, people that are on, I would say I've done a study with Caleb Alexander and Catherine Alexander, that immunodeficiencies and even immunosuppressive medicines don't may be a bit protective in some cases. It's unclear, but asthma and most importantly, hypertension, it does not appear to have a strong evidence basis or qualify as a risk factor, which is a common question that tends to come up. Now, besides all those medical comorbidities and so on, the other factor is that perhaps due to accessing care, socioeconomic reasons, there's clear racial and ethnic predispositions for increased risks for needing the hospital or dying. And this is true for Blacks, also the Latinx population, and Native Americans and Alaskans, whereas, as you can see, non-Hispanics and Asians might even have less of a predisposition. Now, we do have this case here of a patient who's 52, and this is an outpatient scenario. He has hypertension, but is a smoker, and he's been sick for about 24 hours with cough and myalgia. And so his PCR comes up positive. He's only been sick for a day. And the question is, you know, in the outpatient arena, what treatments can you offer him? And of course, I'm still fielding questions, even now, months later, about hydroxychloroquine, ivermectin, a lot of therapeutics that are have been looked at for repurposing, and a lot of people want to take some of these, but unfortunately, the menu for treatment is rather small here. And although there are some promising oral antivirals that might work similar to what we do for influenza with the use of oseltamivir or baloxavir, unfortunately, what we have based for ambulatory patients at the moment are really only antibody-based therapies. Now, before we get into that, on a home care basis, this is what we're still recommending, and that is, you know, for this person, you have to isolate for 10 days if you're not severely immunosuppressed. It's curious to me whether this might actually change, because we know some of the variants of concern, especially Alpha, which is the one first described in Great Britain, Delta, and also the B1351 first described in South Africa, tend to actually have longer periods of infectiousness, up to 13 days. So I've always been curious, as we've seen more of these viral variants, whether this 10-day rule will still be the recommendation from the CDC, assuming that you've had resolution of fever and symptoms. And then the quarantine is still for 14 days for contacts. And I think this question, when I was working on a COVID ward, came up quite frequently, where, you know, people were still not clear about, you know, trying to get people into a sick room at home, for example, even after discharge from the hospital, as they might still be infectious. And those kinds of things with close contacts, people needing to stay home. And I think some of the initial, how should I say, the initial stances that people took, being very careful to follow recommendations a year ago, are not the case, and I often see people not adhering to quarantine recommendations if they're unimmunized. Of course, if you're immunized, you do not need to worry about such. As I mentioned, for this outpatient, there's really only antibody-based therapies, and these really work as antivirals. You know, the first one that hit was the single monoclonal bamlanivimab out last fall. This was no longer distributed, and these drugs are free of charge at the moment in the United States because it did not have good activity against some of the viral variants of concern. But the combination with etesevimab was maintained as one that would still be used, but just last week, and not in enough time to change the slide deck, this drug is no longer being distributed. It's paused by HHS, that's Health and Human Services. So the recommendation is not to use because in vitro assays, which use a pseudo-neutralization viral assay, found that there was just less and less efficacy, especially against some of the variants of concern that I had discussed previously. But the drug did work against earlier viruses and did seem to reduce the risk for dying or hospitalization. And the good news is that these findings were not unique to that particular product. This drug, casirivimab and indivimab, is the one that's also known as the one that the president received last fall. And this looked at patients with mild outpatient COVID. Typically, they got the dose around day 4 or so. In this particular population, there were a substantial number of patients with risk factors, as well as some of the populations at higher risk. And you can see that there was a substantial reduction in the need to enter the hospital or die. And indeed, it even shortened the duration of symptoms. And more recently, the FDA has used this lower 600 milligram and 600 milligram dose of each monoclonal that not only can be given IV, which was the earlier recommendation, but be given subcutaneously, which is, of course, a much easier method of administration. Now, the reason I'm mentioning this is, of course, patients can still be admitted to the hospital. But I thought it would be important to highlight that even if they did require hospitalization, it's quite possible that this monoclonal antibody also would help shorten the duration and severity of illness in hospital. So I think these are underutilized products because of the need to be referred for them and go to a certain location often and fit criteria. This is something that I think is not used as frequently. A drug that you may not have heard much about was given an emergency use authorization by the FDA in May, and that's sotrovimab. This is a single monoclonal, just like the others, that targets the spike protein. And this is interim results from a phase 3 trial that actually was halted early because it looked like it was clearly efficacious. As you can see here, with an 85% reduction in the need to enter the hospital or death if these were given to patients, outpatients early in illness. And so this too also retains activity in these in vitro pseudo-neutralization assays that are being used to assess efficacy against these variants of concern. So there are 2 monoclonal products that can be employed at the outpatient arena. This gives you an idea of what sort of has happened with some of these. This is a snapshot of these pseudo-neutralization assays because you don't want to work with a live virus. But you can see that bamlanivimab and the combination was really losing ground against many of these variants. And especially if the change was over 1,000, the thought is it would correlate with no activity in human illness. But I think this is getting more attention, especially updated with some of the Kappa and Delta variants. But importantly, at least it looks like the two columns on the right have held up, although additional studies are in progress. So these drugs remain at the moment for outpatients only, at least if you're using it per the EUA. You have to be an adolescent or an adult and have one of the risk factors and have 10 days or less of illness. Now, earlier is always better with monoclonals. And as I said, some of the studies were at day 4 or so on average. And I encourage, if you happen to have any outpatient influence with patients, to try to get them to call their doctor, get tested, and get this as soon as possible. This is especially true because we've seen a number of terrible illnesses in patients with immunosuppression, people that do not respond to the vaccine well. They may have an organ transplant or active malignancy, and these drugs can truly be life-saving, I believe, in this population. The fact sheets are listed below for details additionally. And I will say in the last month plus, the FDA did loosen criteria a bit to include a wider range of conditions, those that were sort of on that left-hand column on the evidence basis table that I mentioned. So you know, if you have a thought that your patient may be at risk, it's worth checking that list. And again, if they're early in illness, please refer them for consideration of this. I think once you've done it, it's much easier, and I think the message is not out as much as it ought to be. So again, giving it early, and you know, testing is available, but people I think are not seeking out testing now. They're sort of staying home longer. This is sort of what happened early in the pandemic, and I hope this trend doesn't continue, even though the numbers nationwide are down. The concern is that we could have another spike in the fall as more indoor activities amongst the population that either doesn't respond well to the vaccine or chooses not to be immunized. It's not yet authorized for use in hospitalized patients, but I do want to highlight an aspect there momentarily. Just to review, these are the current recommendations from the NIH and IDSA that no doubt will be updated to strike the bamlanivimab and etesevimab to use them. And so the evidence has improved such that these are really recommendations at this stage and important. This study, I think, is very important if you're taking care of hospitalized patients. The recovery trial, which has given us a great deal of information from the UK in this pragmatic trial, had an arm of using the combination cocktail here in almost 10,000 patients. Now, the UK is interesting in that patients tended to get to the hospital a little later, but this was the second week of illness on average. Patients were presenting day 7 to 9, and most were getting steroids as standard of care. But the interesting part of this is that if patients, when they were enrolled in the study and got the monoclonal antibody, if they were seronegative, suggesting their immune system was either incapable or had not yet mounted an antibody response to the spike protein of the coronavirus, that there was a mortality benefit. And so this mortality benefit was about 20%. It held up statistically, but if you looked at all comers, it did not. And this included, of course, the seropositive population there as well. But in the seronegative population also seemed to prevent progression to needing mechanical ventilation, as well as the mortality benefit. So this is something that we'll see if this is incorporated and used. So it may be something that, again, I think speaks to the potential even for high titer convalescent plasma, which is less used, but really that study, which I'll just mention, I forgot to say, used a very high dose of the monoclonal antibodies, 4 grams, as opposed to 600 milligrams on an outpatient basis of each of the monoclonals. So it is something that you may see as a consideration in the next month or two, depending on the FDA and the company seeking approval. So here we are with the patient who 2 days later did not get monoclonal antibody infusion because even though he was a smoker and had diabetes, which were risk factors, but he was feeling worse, presents with a high fever, some tachycardia and elevated respirations with a pulse oximetry of 84%. So at this stage, I'm going to hand it over to David for a discussion of hospitalized patients and considerations of treatment, and starting off with antivirals.
Thanks, Paul. And thank you, Faith. Appreciate being here. As a hospitalist, we're admitting these patients, we're following through them throughout the hospital, and we're choosing if and when to discharge them. So talks like this where we can really drill down as to the tools that we have to help these people are so important. So thank you so much. Now, Paul, before I get into remdesivir specifically, Mr. A in this clinical scenario chose not to get monoclonal antibody therapies as an outpatient, but a few of our patients who end up hospitalized do have those therapies in their past medical history. When I'm admitting patients who have received a monoclonal antibody as an outpatient, are there any considerations that I should have as to what I should be looking for, or medicines that I shouldn't prescribe because of an unknown interaction, or is that data just too early to know?
Well, I think monoclonals generally, if someone had the infusion, sometimes they're getting the infusion too late. It's far along into their illness. But typically there aren't really any drug interactions. I think the question that comes up most frequently if someone's not been immunized is when they should be immunized. Interestingly, the current recommendation is to wait 90 days. I'm not sure that makes sense. If you have hepatitis B, we give exposure, we give immunoglobulin and then immunize people all the time. We do the same with rabies. There's no great data suggesting this 90-day wait, but that's what's out there. I guess the idea is people will generate, hopefully, some immunity once they have coronavirus, but there's no scarcity of vaccine anymore. So, but in terms of any specific drug selection, I don't think so. The only item I would make is just quickly, there is this whole controversy if you're seronegative, which you won't know for most of your patients. If you're giving a monoclonal antibody product, giving steroids, it seems to suggest to lessen the impact of the therapy. We know that from convalescent plasma. That's about the only thing, but just from a practical basis, most people are not checking the spike antibody levels on their patients. And of course, here you're giving a monoclonal and you're not going to have that data, basically.
Perfect. Thank you so much. So now Mr. A is showing up to our triage center. We've admitted Mr. A for what sounds like viral sepsis secondary to COVID-19 pneumonia. So let's talk about the tools that we have at our disposal to try to minimize the impact of COVID-19 on Mr. A. The first drug that I'd like to talk about is remdesivir, and specifically the ACT-1 trial. So remdesivir inhibits RNA-dependent RNA polymerase. It's essentially a chain terminator for the virus. The ACT-1 trial was a double-blind randomized controlled trial where they looked at remdesivir versus placebo. The patients that they looked at, their inclusion criteria were people who were tachypnic over 24 breaths a minute, people whose pulse oximeter read 94% or less on room air, people who required new supplemental oxygen in the setting of their COVID-19 infection, or people who were requiring non-invasive or invasive mechanical ventilation. And interestingly, they excluded individuals who they thought would be discharged from the hospital within 72 hours or less. Their primary endpoint was what's called time to recovery on their ordinal scale, which was leaving the hospital either on or off supplemental oxygen, or if the patient was hospitalized but for a non-medical reason. So, for example, if they needed to be placed in a nursing facility and their hospitalization was prolonged for a social or an administrative reason. What they found were positive results independent of glucocorticoid use. They found that patients not only left the hospital sooner, but they also found a mortality benefit in the use of remdesivir. This graph shows a Kaplan-Meier curve of cumulative recovery, showing that the patients who had received remdesivir, their recovery was maintained over the full 28 days of study. The patients who required supplemental oxygen, but who were not sick enough to require heated high flow, BiPAP, or mechanical ventilation, showed the most benefit from remdesivir. But the patients who were on mechanical ventilation had little to no benefit from remdesivir, which in retrospect makes sense given what we know about the life cycle of the virus and the waning effectiveness of an antiviral medication after the virus has already replicated. Interestingly, the patients in between, the population who required high flow oxygen or non-invasive ventilation, were shown to have and Paul, please correct me if I'm wrong, a transient benefit, but when plotted out over the full 28 days, the number of patients who recovered was about the same. Importantly, remdesivir was found to be essentially a benign intervention. The medicine was safe. The adverse effects were about the same across remdesivir versus placebo. Like we talked about a few slides ago, different ethnic groups have different rates of hospitalization and mortality from COVID-19. And those patients had, prior to this retrospective trial, been severely underrepresented in clinical trials. It's thought that likely social determinants of health are a main reason why non-white patients have higher morbidity and a higher mortality. And so it was important to study these underrepresented groups. Additionally, while the Act 1 trial had some individuals receive glucocorticoids, glucocorticoids weren't the standard of care when Act 1 was underway. And lastly, Act 1 gave people 10 days of remdesivir. And there was a concern that we might face a global remdesivir shortage. So it was important also to determine if a shorter course could also be effective. This study was a retrospective case control study of people who had been admitted with COVID-19. And about 80% of them self-reported as a non-white ethnicity. They found that the time to clinical improvement was shortened in patients who were given remdesivir compared to those who weren't. Additionally, the mortality at 28 days was decreased in patients who were given remdesivir compared to those who weren't. And importantly, these patients were overwhelmingly given a 5-day course of remdesivir rather than a 10-day course. If you look at the bottom, the last bullet, these patients didn't show significant difference in the cohort who received remdesivir alone compared to those who received remdesivir plus steroids. However, this is somewhat the fault of the retrospective case control format of this study. The people who did receive steroids were significantly sicker at baseline. About twice as many of them had COPD or other chronic lung disease, and more of them were severely ill in general. This plots out 3 Kaplan-Meier curves The one to the absolute left shows the difference in the patient populations with severe disease, which they defined as the use of high-flow nasal cannula, non-invasive ventilation, mechanical ventilation, ECMO, or pressors. And while it does look like there is a difference between those two curves, the benefit was not statistically significant. There's not enough daylight between those two. And as you can see from the middle and the rightmost graphs, there are benefit in their moderately ill patients as well as the patients who were who retrospectively would have been in the Act 1 trial. So from these two trials, the NIH recommended that hospitalized patients who were on supplemental oxygen but not invasive ventilation or ECMO receive remdesivir. Remember that people who are not sick enough to require supplemental oxygen didn't seem to have much benefit from remdesivir. And likewise, the IDSA recommended that patients with severe COVID-19, so those who were not hypoxic based on Medicare standards, so below 88%, but people who were below 94%, or at or below 94%, or requiring supplemental oxygen but not requiring mechanical ventilation or ECMO, receive remdesivir. It's always challenging as a generalist, especially when many trials are coming out very, very quickly. It's always challenging when there's seemingly discordant data. The Solidarity trial is a trial that looked at multiple different repurposed antiviral drugs to see if any of them could impact mortality. The remdesivir arm is ongoing, but currently they're reporting negative data. And Paul, if you wouldn't mind giving me an assist here, I'm trying to reconcile the results of this larger study with that of Act 1. And my main challenge is when I'm looking at their methods, I'm not quite sure what they're actually doing. Would you mind helping me out with how to reconcile the Solidarity trial with my clinical care?
Yeah, so David, it's great because I think remdesivir, some people have looked at this extremely large trial and said, look, there's no mortality benefit. Why should we use it? And indeed, many countries in Europe have not adopted it. Brazil hasn't, on the basis of this study. Now, the Act 1 trial is a gold standard RCT, placebo-controlled, very well done with rigor. This is a pragmatic trial, no placebo arm, and there were 3 other comparator arms, like a lopinavir, ritonavir arm, there was a hydroxychloroquine arm, and so on. So there are 4 groups, and investigators were allowed to switch patients among groups if they felt there was a need to switch. Also, it was not, the randomization, as it were, wasn't across the board. This was done in many sites. But most of the remdesivir arm, or a great majority of it, was performed in Iran. So you could argue that perhaps this study doesn't quite reflect what we do in the United States. Now, the Act 1 trial statistically didn't show mortality benefit. There was a mortality trend. It was more the reduction in the length of stay. So, as an infectious disease doctor, I think, people that do have ongoing viral replication may benefit with remdesivir. I think others would say there's really no benefit based on this trial, but I think there's a lot of limitations here. There's probably some groups that could benefit, but this Solidarity trial really was meant to happen quickly. I mean, they get a lot of kudos for setting this up early in the pandemic, but it had limited data acquisition. So it's not nearly giving us the kind of information where the drug may have some benefit. So 2 different studies, 2 different results, people choose to interpret differently.
Thank you. I think not even for the time being, I think we'll continue using remdesivir. I think, something like 405 hospitals were enrolled in this, and it sounds like they were using different methods of enrollment. So we'll stick with IDSA and NIH. Moving on from remdesivir, there was this idea early on in the pandemic, especially before other agents had rolled out that convalescent plasma could be beneficial in patients with COVID-19. There are other illnesses in which convalescent plasma can be helpful. And while my understanding is the specific mechanism of action of convalescent plasma is not entirely known, we do know that it can act as a neutralizing agent. So anti-spike protein IgG can bind and neutralize the virus, can stop it from host invasion. And there is some idea that it can also help moderate the hyperinflammatory response in a way similar to IgG. IVIG, my apologies. So people were using convalescent plasma in the hopes that it would help, which led us to this trial. This was a retrospective study looking at individuals hospitalized with COVID-19 who either had severe illness or who were at high risk of developing severe illness, who had received convalescent plasma with a known titer. So convalescent plasma, the anti-SARS-CoV-2 IgG, it can't be concentrated. So the bag of plasma is the bag that you have. So the question was, could doses of convalescent plasma that had a higher titer of anti-SARS-CoV-2 IgG be more beneficial? For this study, the primary outcome was death within 30 days after the patient was transfused. And what they found was that patients who were intubated had no benefit from convalescent plasma. This study, patients were very sick. Almost 2/3 of them were in the ICU, and about 1/3 of them were on mechanical ventilation. So the patients who were on mechanical ventilation didn't seem to have benefit from convalescent plasma. However, the patients who were not intubated did have benefit. And that benefit seemed to be dependent on the titer of anti-SARS-CoV-2 IgG in the plasma they received. Interestingly, people also had a lower mortality if they were given plasma within 3 days of diagnosis compared to those who had received plasma later in their course. This speaks to convalescent plasma's presumed ability to neutralize the virus or block host entry, given that such an effect would be more beneficial early in the course while the virus is actively and robustly replicating. One thing that the authors of this paper did say was that the highest predictor of mortality wasn't the titer of convalescent plasma, but it was simply the age of the patient who received either intervention or placebo. Which brings us to this study, prevention of severe COVID-19 in the elderly by early high titer plasma. So this was a double-blinded randomized controlled trial. They included patients who had symptoms for 72 hours or less. We've already talked about just now that people who have been diagnosed earlier on could have more benefit from convalescent plasma. So this study just looked at people who had symptoms for 72 hours or less. And given that elderly patients are the most at risk, they only included patients who were either 75 years of age or older, or patients who were 65 to 74 years old with at least one significant comorbidity. And the patients were stratified based on the titer of anti-SARS-CoV-2 IgG in the plasma they received. Their primary endpoint was progression to severe respiratory disease, which they defined as tachypnea above 30 or oxygen saturation below 93 in the 15 days after receiving the transfusion, though they excluded the first 12 hours post-transfusion to try to exclude patients who developed TACO or TRALI from the transfusion itself. And what they found was that the patients who had received the highest concentration, the highest titer of antibodies, had the most mortality benefit. Now, I'm going to pause there. Paul, with these two trials, I think we were hopeful that convalescent plasma would be able to be widely used. But the recovery trial, which has almost all of the available data for convalescent plasma, seems to suggest that there's not much of a benefit. So again, how can we kind of explain these discordant results together?
Well, I think simply put, David, recovery, as you can see here, contributed most to these trials. A lot of these trials were cut short because in China they ran out of infections to treat and so on. But if you look at recovery, the average day of illness to administration is day 9. They're already well into that second week of illness. So again, I think we've sort of looked at it and said, if you're early in illness, there's potential for benefit if people are presenting to be hospitalized. But the other group, which none of these really address, are the people that don't mount antibody responses. And I think we know who those are. So we don't have the perfect trial for plasma yet. It's really the only antibody-based therapy we have for hospitalized patients at this time.
Thank you so much. And it looks like when we pull out the recovery trial data, it almost seems like the data suggests that plasma would be effective. But again, you said, after you.
Oh, I'm sorry. Yeah, I was just saying, yeah. And so this was with mechanical ventilation use and preventing that. So, again, it looks like you're getting people earlier in the illness, not all comers. Yeah, right.
Gotcha. Thank you. So from there, the true recommendation for the use of convalescent plasma is extremely mixed. So we don't have any strong recommendations on the use of convalescent plasma. However, in people who are unable to mount, who have been shown to be unable to mount an antibody response, it seems to be reasonable to use convalescent plasma even in the absence of high quality, robust data. Moving on from remdesivir and convalescent plasma, one of the, or probably the most widely used intervention is glucocorticoids. So the recovery trial arm for dexamethasone looked at people who were not on oxygen or ventilated, who had COVID-19. And what they found was that in the patients with whom dexamethasone was used, ventilated patients had the highest relative mortality benefit with a number needed to treat of, I believe, 8. So this was huge. That was followed by people who were on oxygen but who were not ventilated with a number needed to treat of 34. And people who were not on oxygen had no benefit and even trended towards harm in receiving dexamethasone. Interestingly, people who had symptoms for longer than 7 days had the most benefit in terms of reduced mortality, which in retrospect makes sense, as after viral replication, most of the damage that's done with COVID-19 is because of that hyperinflammatory state. So if you target patients who've had this disease for longer with an anti-inflammatory medicine, one would expect a more efficacious drug. Interestingly, dexamethasone didn't just show a strict mortality benefit. It was also shown that patients were less likely to need non-invasive ventilation. They were less likely to need to be intubated. If they were intubated, they were less likely to, or they were had fewer days on the ventilator. They were weaned safely off the ventilator sooner. Length of stay was shorter. They were easier to discharge. And even from a non-pulmonary perspective, fewer patients needed to be on hemodialysis who were on the dexamethasone arm. So from this, dexamethasone was kind of widely used and is still widely used. So now we go back to Mr. A. So Mr. A, we've admitted Mr. A into the hospital. We've given Mr. A remdesivir. We've started him on dexamethasone, but either it was too late in the course of his illness, or he had too many comorbidities, or he was just one of those patients who downtrended. And 72 hours after we've admitted Mr. A into the hospital, we're called for hypoxic respiratory failure. And he's transferred to the ICU and started on BiPAP. We check a CRP, and Mr. A's CRP is found to be incredibly elevated. So now the question is, what other interventions can we do to assist Mr. A in his recovery? We've known that elevated levels of inflammatory markers, including IL-6, have been associated with mortality in COVID patients. So it was thought that giving IL-6 blockade with an IL-6 receptor blocker could improve clinical outcomes. So there were several early trials with Tocilizumab to see if Tocilizumab was effective in any way, shape, or form in helping patients who had COVID-19. The challenge with these early trials, and I won't go through all of them in depth, but the challenge with these early trials is that they all had different methods, they all enrolled different patient populations, and they all enrolled people with in different time courses of their disease. Most of these trials had kind of mediocre results at best. The Stop COVID trial did show that maybe there was some benefit, but the patients who received Tocilizumab were also somewhat younger and healthier. So from these early trials, it was difficult to really hope for this drug. But we did find a few kind of core features from these early trials. We found that it didn't harm people. It seems to be a benign intervention. Some folks would develop mild neutropenia, but that neutropenia wouldn't correlate with more infections. And we found that it didn't work on its own. However, in the patients who were receiving dexamethasone or other steroids, there seemed to be some benefit. The REMAP-CAP pragmatic trial looked at ICU patients who had been in the ICU for a day or less. Almost 90% of them were also on steroids. And what they found was that hospital mortality was less, 90-day mortality was less. And interestingly, the effect was most pronounced on the patients who had the highest CRP. But it was a fragile study. The status of only 3 people would have to change to make the results statistically insignificant. Which brings us to the Tocilizumab arm of the recovery trial. Like the other arms of the recovery trial, it was a large multi-centered study. It included hypoxic patients admitted to the hospital with COVID-19 with a CRP above 75, and almost all of them received steroids. And what they found was that mortality was decreased, rate of mechanical ventilation was decreased, and length of stay was decreased. So from that, we can assume that while Tocilizumab doesn't work well on its own, it works very well in people with a hyperinflammatory state who are also on steroids. There are other interventions that we can use. And Paul, would you mind telling us about some of these other agents that we can provide for our patients?
Yeah, so, David, I think you're right. Tocilizumab, which, a lot of people embraced early, sort of was a dud. But when combined with corticosteroids, it looked like this very targeted anti-IL-6 receptor blocker seemed to yield benefit, mortality, and decreased severity of illness. These JAK kinase inhibitors, baricitinib's one, they're approved for rheumatoid arthritis. There have been 2 trials, one just using the drug alone, which only had a 1-day benefit, the Act 2 trial, the brother to the sister, I should say, to Act 1. But a more recent Cove barrier trial, because steroids became the standard of care, combined it there. And you can see there was a risk reduction here, but it didn't, with the mortality benefit. But interestingly, their primary endpoint, which was combined lack of progression, death, it wasn't met. It's a confusing trial, but these drugs, I think, have a potential role because, like steroids, these inhibit a lot of signal transduction and are just to have a broader action like steroids compared to this kind of very targeted inhibition of IL-6 by Tocilizumab. There are no head-to-head trials, so for the moment, the NIH and so on say you can use either a baricitinib and remdesivir, or you can use Tocilizumab and Dexamethasone. So you can sort of combine them, as 3 potential agents with your options of Tocilizumab or baricitinib. Personally, I don't think baricitinib's been widely adopted yet, just because the strength of evidence is lower. And so Tocilizumab seems to be the option. So when we look at our patient, he did receive remdesivir, dexamethasone, and Tocilizumab. He was getting worse. This is where there's probably that sweet spot for an additional agent, and he improved and was discharged home. Post-discharge, there are a lot of issues that we could probably tackle, but I just wanted to summarize a couple of key points here that monoclonal antibodies are available. And again, for patients with risk factors, I think they're so important to consider, hopefully early in illness, as all antivirals are. Remdesivir is the only FDA-approved drug. Remember, the people that benefited most were those that needed oxygen in the Act 1 trial. Those who weren't on oxygen were a small number. There may be benefit, but you'd have to treat so many patients to show benefit. It's not one that's been used widely for that patient population. And it did shorten the duration of illness by 5 days. And I think some other retrospective data supports this idea that it will shorten duration of illness, which I think is still an important reason for consideration of it. Any antibody-based therapy or antiviral, if you can use it as early as possible, you'll have a better benefit. And remember, dexamethasone lowers mortality, and now there's some evidence to suggest Tocilizumab does as well. So, Faith, we're going to move on now to a post-test consideration.
Thank you again to our learners for that. As a reminder, to submit a question, please click the Q&A button at the bottom of your console. We'll try to get to as many as time does allow. I'm going to toss this first one over to Dr. Auwaerter. This learner asks, what is expected this summer and fall as far as the spread of the Delta variant and its effect in areas with low rates of vaccination?
Right. Well, I've learned one should never forecast what this virus will do. But I think the concern with the Delta variant is that there is increased transmissibility. We've known that. It now accounts for 20% of our viral isolates that are sequenced in the United States. So much like the Alpha variant, it's established a foothold and is rapidly replacing others. A number of modelers predict a fall upswing. Again, it's going to be in the population of people that are unimmunized or don't respond well. So that's why there's still great emphasis to try to get as many people immunized as possible by a variety of methods. So I think there will be some seasonality to this virus, and much like RSV and influenza, we'll see more of it come the fall.
Okay. Dr. Klimpl, how often is remdesivir used for less than or more than 5 days?
Oh, that's a great question. So in general, remdesivir is used for 5 days or until a patient is discharged from the hospital. Patients can be on remdesivir for fewer than 5 days if they have dramatic clinical improvement if they're discharged from the hospital. I am not aware of any of any clinical scenario where remdesivir will be prolonged past 5 days, based on our findings that it has benefit with a shorter course.
Fantastic. Oh, okay. And our next question, do we know how long vaccine-induced immunity lasts? Will boosters be required?
Well, I'll jump in there. This it's a question everyone asks. Interestingly, the mRNA vaccines look like they're increasingly more potent, mainly because they may also have better T-cell responses and so on. So the antibody kinetics so far suggest we'll have protection a year and more. Of course, time will tell on this, along with protection against some of the variants, some of which may still yet emerge. So although people are planning for a booster, at the moment, I would say that's quite undecided. And my hopes are, at least for people that have received Pfizer or Moderna, there may not be a need.
Okay. That is going to conclude, in the interest of everybody's time, our Q&A for today. Got a lot of really good questions. Do stay tuned for some of our upcoming webinars, and we will hopefully be able to answer those there. For the audience, if you'd like to claim credit, please click on the Claim Credit button. It will appear when the webcast ends, and be on the lookout for our 30-day survey. You'll receive that in your email, and as always, your responses will help us develop further education. Thank you so much for joining us, and have a great day.